Hi, I am Jeremy Kortmansky. I am a GI medical oncologist at Yale Cancer Center. I am joined by Dr. Saj Khan, who is a surgical oncologist at Yale Cancer Center. And today we'd like to talk to you about hepatic arterial infusion and the potential benefits and risks for your patients. Over the last couple of decades, we have seen that there may be several contributions for hepatic arterial infusion chemotherapy for our patients. We have seen in patients with unresectable colorectal liver metastases improvements in tumor burden, disease control, and an increased likelihood of conversion to surgical resection. In patients that have already had surgery, HAI can prevent recurrence and improve overall survival. And more recently, we have seen in patients that have intrahepatic cholangiocarcinoma, HAI therapy can improve overall survival in these patients as well. Hepatic arterial infusion therapy is a way to deliver chemotherapy directly into the liver, and it takes advantage of the unique anatomy of the liver and the properties of floxuridine to safely achieve high doses of regional therapy while limiting toxicity elsewhere. Liver metastases are perfused by the hepatic artery, whereas normal liver cells or normal parenchyma is perfused by the portal vein. HAI can deliver floxuridine into the hepatic artery, delivering it concentrations of chemotherapy that are 400 times higher than those achieved by IV administration. But yet that is metabolized within 10 minutes, rapidly removing the drug from the body and limiting systemic exposure.
Colorectal cancer, liver metastases is a common problem that many patients are faced with in the United States. Colorectal cancer is one of the most common cancers diagnosed in America, and it's the third leading cause of cancer-related deaths. Over 150,000 people have been diagnosed with colorectal cancer each year. Even though the incidence is going down, it is still one of the leading causes of death. It is a leading cause of cancer-related death, specifically in men under 50, and the second leading cause of cancer-related deaths in women under 50. Colorectal cancer is interesting in that 50% of patients ultimately develop liver metastasis, which provides a bit of a unique biology compared to many other cancers, and hence it can affect how patients are treated. 20 to 34% of colorectal liver metastasis patients present with synchronous colorectal cancer liver metastasis, which means that the cancer is diagnosed at the liver metastasis is diagnosed at the same time that the primary colorectal tumor is diagnosed as well. And the majority, though, do present in a metachronous fashion, which means that the liver metastasis develops at a later time point, not at the time that the primary tumor was identified. Conventional systemic therapy, systemic chemotherapy alone has limited efficacy in patients with colorectal cancer liver metastasis, and the 5-year overall survival is less than 14% with currently existing systemic regimens. 2% of patients have a durable response at 5 years. Going to the point earlier that we had mentioned that the treatment for colorectal liver metastasis is a little bit different than in this scenario than other kinds of cancers, particularly for GI cancers. Surgical resection does offer the best chance for cure and for survival and possibly cure. However, still only a fraction of patients can be resected. And we have some data here that are showing that patients that have 5-year survival that are initially resectable can be 46% at 5 years and 25% at 10 years. And for those patients that are converted to resectability, 32% and 23% at 10 years. But only 20% of colorectal liver mets patients are candidates for liver resection at the time of diagnosis. Systemic chemotherapy and biological therapies have limited impact on improving the patient's chance for resection. And the definitions for resectability are subjective and surgeon dependent to a certain extent. It is generally believed that with first-line systemic chemotherapy and biologic therapy, only 5 to 15% of patients may become resectable. And more aggressive chemotherapy regimens have improved response rates, but have not consistently translated to improved resectability and are associated with significantly more toxicity with the systemic approach. Majority of patients do recur post-resection, and adjuvant chemotherapy does not necessarily improve survival. 75% of patients will recur within 2 years after their hepatectomy or hepatic metastasectomy, and 50% of patients uniquely recur within the liver. Adjuvant systemic chemotherapy after colorectal liver resection does not significantly improve overall survival. And there are 2 references here from Portier et al., where patients were treated with adjuvant 5-FU versus surgery alone, and the perioperative approach by Nordlinge, published in 2013, where there was not a clear improvement in median overall survival or significantly or clinically significant improvement in median overall survival with the perioperative systemic chemotherapy approach added to surgery. Hence, hepatic arterial infusion pump therapy can have benefit to patients with colorectal liver metastases. The reasons to do this, or the applications for a hepatic arterial infusion pump, is to convert some patients to resection. So HAI may reduce the tumor burden, particularly in the liver, improve the disease control within the liver, and increase the likelihood of conversion to surgical resection. Survival impact is independent of resectability. So HAI and systemic chemotherapy may improve overall survival in patients who still are not candidates for resection. So there is benefit. Adjuvant colorectal liver mets therapy does have application as well too. So in an adjuvant fashion, treatment with HAI can reduce recurrence and have a favorable impact on survival. HAI may reduce the likelihood of recurrence post-resection without increasing systemic side effects. And HAI is the only adjuvant therapy for resected liver mets shown to improve 2-year survival in a randomized trial, which we'll talk a little bit about later.
I'd like to take some time now to review specifically the data that has been developed to guide these benefits for hepatic arterial infusion, starting with unresectable colorectal liver metastases. In this study by Pak et al., published in the Journal of Surgical Oncology, we see that patients who were heavily pretreated still experienced an overall response rate of 73%. In the study, there were 64 patients from a single center. 67% of them had already had at least 1 line or 2 lines of prior therapy. And those patients had a high tumor burden with a median number of 13 liver tumors per patient. Yet there was still an overall response rate of 73%, higher in patients who were chemo naive, but 67% in patients that were previously treated. And 50% of those patients were converted to resection. And what we see is in those patients that were converted to resection, there was a 63% 5-year survival, similar to those patients who were considered initially resectable at diagnosis. For patients who were not resectable, their survival was still improved at 36% for the entire cohort, but not as good as those who were converted. But for those patients who remain unresectable, there is still a benefit for HAI therapy. And in this study, a case control study from the University of Pittsburgh, in patients who were receiving HAI therapy as either second or third line therapy, there was still a benefit in overall survival, with a median survival of 32.8 months for hepatic arterial infusion plus systemic chemotherapy but only 15.3 months for patients that had systemic chemotherapy alone. When using HAI as a first-line therapy in combination with systemic chemotherapy, the results look even better. This is a single-arm study out of Memorial looking at 58 patients who were chemo naive, who had a high tumor burden, who had KRAS or BRAF mutations, and were receiving a modern systemic chemotherapy regimen, including oxaliplatin and irinotecan, in addition to the 5-FU. And in this study, there was a 79% overall response rate and a 62% conversion to resection or complete response without resection. The median overall survival for those patients who achieved conversion or complete response was 142 months, compared to 28 months for those patients who did not convert. That 28 months is a similar number for what we would expect for patients with metastatic disease. 3-year overall survival was 88%, and 5-year overall survival was 72% in those patients who had a conversion to resection. So it's clear that HAI therapy can play an important role in all lines of unresectable colorectal liver metastases, including those patients who have had prior therapy, as well as those patients who are chemotherapy naive. And these benefits can be seen by converting to resectability, and in patients that even don't achieve resection are still appreciating a better benefit. Switching to adjuvant therapy, there have been a couple of important studies that have shown the benefit of adjuvant therapy. This first study was published in the New England Journal of Medicine in 1999 and was a randomized controlled study of 156 patients comparing HAI with systemic chemotherapy versus systemic chemotherapy alone in patients that had had resection of their disease. And in this study, there was an improvement in overall survival with the addition of HAI from a 2-year median over survival, or 2-year survival of 72% in chemotherapy alone and 86% in the HAI group, with a significant improvement also in the survival free of hepatic recurrence. One of the criticisms of this study was that it was a single institution study and that the systemic therapy was 5-FU alone. But in this study, which looked at adjuvant HAI therapy from Europe, these patients had received modern chemotherapy regimens, including those containing either oxaliplatin or irinotecan, and showed a similar improvement in both 5-year or median overall survival, 5-year survival, and 10-year survival up to 38% with the addition of HAI. And when you look at patients specifically who received the irinotecan or oxaliplatin, the benefits of the HAI were maintained with an improvement in median overall survival from 47 to 67 months. Lastly, I'd like to talk about some of the emerging data for intrahepatic cholangiocarcinoma. For the vast majority of patients with intrahepatic cholangiocarcinoma, their disease is unresectable, and even when resectable, recurrence rates are very high. This is a rare disease compared to colon cancer, affecting 4,000 to 5,000 patients each year. But only 20 to 30% of those patients can be resected. And in those patients, 70% can have recurrence after that curative resection. And ultimately, 70% of all patients who are diagnosed with intrahepatic cholangiocarcinoma succumb to their disease. Patients with unresectable disease confined to the liver have a poor prognosis with chemotherapy alone. This is data from the ABC trials of gemcitabine and cisplatin compared to gemcitabine alone, which showed a median survival of 16.7 months for liver-only disease with standard chemotherapy, with the vast majority of patients succumbing to their disease within 2.5 years. In a systematic meta-analysis of 9 publications with HAI, it was seen that overall survival can be improved compared to these historical controls, with 1-year overall survival of 86% and 3-year survival approaching 40%. With HAI, 1 out of 3 patients with liver-combined disease can be alive at 3 years. And this was presented at the most recent ASCO GI meeting in 2024 with data from the PUMP2 trial, in which patients were treated with HAI plus gemcitabine and cisplatin systemic chemotherapy. And in this study, we saw, again, 3-year overall survival of 33%, with a partial response rate of 46% and disease control at 6 months of 88%. Now, we'll admit that the landscape for intrahepatic, for all cholangiocarcinomas, has really changed with the addition of immunotherapy to gemcitabine and cisplatin for patients with locally advanced disease and metastatic disease. And it is hard to make comparisons between HAI, which was primarily for unresectable disease, but locally advanced, compared to the immunotherapy trials, which had only a small percentage of patients with locally advanced disease and the majority with metastatic disease. And so the use of HAI is evolving, but clearly demonstrates benefits and the potential for conversion in patients with intrahepatic cholangiocarcinoma.
So over the years, there's been improvements in HAI therapy, reflective of a lot of the work that's been done, some of which is cited below. So now in 2024, there's modern HAI therapy, and we've seen improvements to HAI from refined treatment protocols. So the selection of fluoxetine over other drugs for use in the pump has shown to be effective. There's been refinements in the dose of fluoxetine, and with advances in technology, such as with nuclear medicine and intraoperative findings and radiographic findings, there's prevention or reduction of extrahepatic perfusion. There's also, as we've learned more about it, reduced biliary toxicities with lower doses of fluoxetine, the addition of dexamethasone, and careful monitoring of LFTs and adjustment for doses accordingly. And the growing body of clinical evidence, which shows data from multiple centers, which have demonstrated that HAI therapy has an impact versus systemic therapy alone in all applications, some of which Dr. Kortmansky had mentioned earlier with unresectable and adjuvant colorectal liver metastasis and unresectable intrahepatic cholangiocarcinoma. These are general selection considerations for HAI therapy, and these are just general slides as well too. And again, we'll talk a little bit more towards the end about the multidisciplinary and teamed approach that's necessary for good outcomes. But for selection considerations, patients must have a histologically confirmed colorectal liver metastasis or intrahepatic cholangiocarcinoma. They have to be fit to undergo a major abdominal operation. It's not a minor procedure to have this pump placed. There has to be no evidence clinically laboratory from blood work or radiographic evidence of portal hypertension or portal vein thrombosis. Patients must have a preserved hepatic function with the total bilirubin of less than 1.5. They need to have favorable hepatic anatomy with the patent gastroduodenal artery with adequate length and caliber, and limited extrahepatic disease. This is a busy slide, and the purpose is not to go over all the details, but one can reference back to this slides. But this is provides a general algorithm of HAI therapy candidates for patients with unresectable intrahepatic cholangiocarcinoma, unresectable colorectal cancer liver metastasis, and resectable colorectal liver metastasis for consideration for adjuvant HAI therapy is considered. We'll leave this here just for a reference for folks to go back to if they'd like to. This is a general schematic of what one of these pumps look like. So they're about a hockey puck shape size pump that's inserted into the abdominal wall. There's a dome septum, there's a needle stop, a refill path, a drug reservoir, a flow restrictor, pump catheters, propellant chamber, an eye for the bolus needle, and a bolus pad. And the purpose for this is just to show that it has very applicable use that's reproducible with the medical oncology team and the nursing staff. And this provides just a bit of an overview for the ease of which this pump can deliver directed chemotherapy. So currently, the pump that we place here at the Yale Cancer Center is shown over here, and it is the only FDA-approved implantable pump for HAI therapy. So what we do is within the operating room, we implant the pump just below the skin in the abdominal wall in front of the anterior fascia. The pump can be performed as a standalone surgery or in conjunction with other scheduled surgeries, sometimes at the time of a primary tumor resection, or sometimes at the same time as a liver resection or ablation. After the pump is implanted, the body heat serves as an ongoing power supply for drug delivery. And there's a catheter that's attached to the gastroduodenal artery, which is what the picture shows on the right there. So the picture shows the hepatic artery, and it shows just below the hepatic artery, the gastroduodenal artery, which is where the catheter is inserted into and secured with sutures that the surgeon places in the operating room. That catheter and the pump in the abdominal wall allows the hepatic artery to continue to receive medication directed to the liver. With any procedure, it's important to understand that there is some risk to it, and it's important. That's why we thought it would be important to put this safety statement into this presentation. The hepatic arterial infusion pump is contraindicated for patients with extensive extrahepatic disease, which you mentioned earlier, and those with limited hepatic function. And there are adverse events of the pump that are those potential risks associated with any implanted drug delivery device. And these include catheter thrombosis, bolus path occlusion, vessel thrombosis, pump dislodgement, seroma, recurrent hematomas, infections, extravasation, catheter shearing, dislodgement or leakage, migration, pseudoaneurysms of the artery, arterial dissection, and extrahepatic perfusion. As far as the process of the pump placement, HAI therapy is typically initiated, so liver-directed therapy is initiated typically 2 to 4 weeks post-operatively, so after the pump is placed, depending on the application. The HAI pump is refilled every 2 weeks, alternating fluoxuridine and heparinized saline. Bi-weekly refills can be administered by trained medical oncology staff and infusion centers. There's specialized training that's involved, but very reproducible. Fluoxetine dosing adjustments are made at each refill. The LFTs are closely monitored and other laboratory tests as well with each refill. And on the conclusion of HAI therapy, the patient will continue to receive periodic refills of heparinized saline or glycerin to maintain the catheter patency. Glycerin slows down the HAI pump flow, allowing for drug holidays of as much as several months between refills. Pumps may be kept implanted indefinitely in cases of recurrence, or they can be removed at a future date as well. So to summarize some of our presentation here, what we've shown thus far is the HAI pump has applicability for patients with unresectable colorectal liver mets, adjuvant colorectal liver mets, and unresectable intrahepatic cholangiocarcinoma. So we've shown that HAI therapy for unresectable liver mets reduces tumor burden, improves disease control in the liver, and increases the likelihood of conversion to surgical resection. We showed that HAI therapy plus systemic therapy resulted in high tumor response rates, and 52% of previously unresectable patients were converted to resectable patients. HAI therapy and modern systemic chemotherapy doubled. The studies have shown that they've doubled the median overall survival from 33 months to 15 months in the second and third line setting, whether or not resection was achieved. In the adjuvant fashion for colorectal liver mets, HAI therapy prevented or delayed recurrence post-resection and improved overall survival. What we showed is that in this setting, the only adjuvant therapy for resected colorectal liver mets was shown to improve the 2-year survival in a randomized controlled trial. HAI therapy reduced the likelihood of recurrence post-resection, and HAI in an adjuvant fashion after resection improved the 10-year overall survival by 60% and demonstrated a superior median overall survival of 67 months versus 44 months. And finally, for the unresectable patients with intrahepatic cholangiocarcinoma in the liver-only setting, HAI therapy increased overall survival. HAI combined with systemic chemotherapy was shown to extend overall survival for patients with unresectable intrahepatic cholangiocarcinoma, with studies consistently showing over 30% 3-year survival. In order for HAI to be effective, one needs a good multidisciplinary team in order to administer HAI, liver-directed chemotherapy in the settings of colorectal liver metastasis and intrahepatic cholangiocarcinoma. Here at the Yale Cancer Center, we do have an excellent multidisciplinary team that enables for the patients to have good outcomes with our HAI program. This is an overview of how we treat patients here at Yale. We first, in a multidisciplinary fashion, patients will be identified that are potential candidates for HAI therapy. We present patients at our multidisciplinary GI tumor board, where we have representation from multiple disciplines such as medical oncology, surgical oncology, interventional radiology, pathology, radiology, social work. We have a lot of people involved, and those are just some of the individuals. Patients will then have consultations with our surgical oncologists and our medical oncologists. Patients will have a consultation with social workers as well too, because that's an important component to success here too. Patients will have a highly detailed scan, which allows us to visualize the arterial anatomy, which is important for pump placement with technicalities at the time of the operation, and it'll come of use a little bit later as well too. Then our team at Yale will place the surgical pump by one of our surgical oncologists. While the patients are still in the hospital, they'll have placement checked by our nuclear medicine team here at Yale to confirm that there's no extrahepatic perfusion and then that there is good perfusion to the liver. And after that, the patients are treated with our medical oncology team, and it is a teamed approach, and they undergo their treatment as such. And if you need more information, or if you would like more information or would like to refer a patient to our Yale Cancer Center team, Dr. Jeremy Kortmansky and I are the co-directors for our HAI program. Though there are other surgical oncologists and medical oncologists that are also treating patients, but we are the co-directors of this multidisciplinary program. If you'd like to get a patient to seeing us at the Yale Cancer Center, we have 2 numbers that are listed there, and we can help take care of your patients.
All right. Well, thank you for participating in this webinar. And certainly, if there are any additional questions, feel free to reach out to either of us at the numbers listed below. Thank you.